This presentation is on drugs affecting the respiratory system. And these are the categories of drugs we'll be looking at in this presentation, starting with bronchodilators. And those include beta-2 agonists, xanthine derivatives, and anticholinergics. These are the inhaled bronchodilators that we have available, our beta-2 agonists, which are short-acting, and our beta-2 agonists, which are long-acting. The beta-2 short-acting are the ones we use for rescue inhalers. The LABAs, or long-acting beta-2 agonists, include Ceravent, which is probably the most widely used, as well as Brovana, Arcapta, and Foradil. And then our inhaled anticholinergics, Tudorza, Atrovent, and Spiriva. So beta-2 receptor agonists. So the beta-2 receptor agonists act on smooth muscle to reverse bronchospasm. And they do this by stimulating the beta-2 adrenergic receptors that increases cyclic AMP. And in doing that, it causes relaxation of the bronchial smooth muscle. But they also play a part in inhibition of the mediators of hypersensitivity. And as you recall, for example, in asthma, we have bronchospasm, we have inflammation, but we also have the hypersensitive airway that needs to be addressed. And these are the short-acting and long-acting beta agonists, albuterol being the most commonly used for rescue inhaler. Xopenex has also been out for quite a while. We don't see terbutaline being used that frequently, at least not in the outpatient arena. Long-acting beta agonists, Ceravent, and the rest of those have really played a major part in maintenance of asthma, persistent asthma. Albuterol has fewer cardiac and CNS effects than some of the other beta agonists, and so it's most often the first line therapy or first drug of choice. Levalbuterol is the isomer of albuterol, and that can have less adverse effects. Salmeterol and formoterol are long-acting beta agonists, so they provide long-lasting bronchoprotection of histamine-induced bronchospasm, as well as exercise-induced bronchospasm. Some precautions and contraindications with the beta-2 agonists: cardiac arrhythmias, hyperglycemia. Of course, as I mentioned, the black box warning regarding the use of the LABAs, or long-acting beta agonists, when they're used as monotherapy. So the risk of morbidity and mortality in an acute exacerbation seems to be true for patients who are not also using something for the inflammation, such as an inhaled corticosteroid. Salmeterol should not be used for children less than 4, but albuterol is safe for children of all ages, and it can be given as a syrup for younger children. Adverse drug reactions with beta-2 agonists. Albuterol is a selective beta-2 agonist with some minor beta-1 activity. So it can increase the heart rate by directly stimulating the beta-2 receptors in the heart and also in the vascular smooth muscle. In the smooth muscle vasculature, that leads to an increase or decrease in diastolic blood pressure, and then you get the reflex increase in heart rate. It also causes beta-2 receptor stimulation of skeletal muscle, and that can lead to some of these central nervous system excitation effects like tremor and nervousness and restlessness. Patients can also complain of headaches. Most of these drug reactions are transient. They will wear off, usually within a few hours. And remember that salmeterol has that black box warning, so there's an increased risk if it is used alone, if a patient is reaching for that in the case of a severe exacerbation. Drug interactions include digitalis, where there is an increased risk of dysrhythmia. Also, any other beta-blocking agents, including beta blocker eye drops. So that needs to be considered, and we often don't think about the patients using eye drops for glaucoma. Tricyclic antidepressants and monoamine oxidase inhibitors can potentiate the effects of beta agonists on the vascular system. As far as indications go, generally in the treatment of bronchospasm associated with asthma and COPD, and there'll be a little bit more about that later. But it can be used for adults and children, and you can use a meter dose inhaler as well as using it through nebulizer. For children, the dosing is based on weight, as you can see there. Also, the beta-2 agonist can be used in combination with ipratropium, which is what Combivent is. Combivent is ipratropium with albuterol. Both albuterol and salmeterol can be used for exercise-induced asthma. However, if a patient's already taken salmeterol for maintenance, it's probably not going to be very effective if used for exercise-induced asthma. In that case, they would want to use albuterol. Albuterol is given 15 minutes before exercise, salmeterol anywhere from 30 to 60 minutes. Leukotriene modifiers can also reduce the symptoms of exercise-induced asthma in about half of the number of patients, but they're still going to need to use an albuterol inhaler before exercise. Education is really important when patients are using a meter dose inhaler. They are not that easy to use, and it is very important to demonstrate to the patient how to use it and have the patient do a return demonstration. And if a patient comes in and is treating their asthma and they feel like they're getting worse and worse, the first thing you need to do is observe their technique. Hopefully they have their inhaler in their purse or pocket because they should be carrying it around anyway, and they can demonstrate to you and you can see how they're using it. If you see a lot of the mist coming out of their mouth, then they're not getting the dose into their lungs. And that's why it's really important when these are prescribed that a spacer also be prescribed for use with the pump. Then the patient is able to pump it into the little spacer, the chamber in the spacer device, and then they actually inhale it from the device. One thing that is important is that they do have to have some adequate inspiratory drive in order to get the medication to the lungs. It's also very important that they take long, slow, deep breaths and try to hold it at the end of inspiration, not a quick breathing, inspiratory method. That is not going to be very effective. All of the inhaled bronchodilators have minimal absorption into the systemic circulation. Most are metabolized in the liver. And you just do need to become familiar with the onset, peak, and duration when you're prescribing these, because they do vary. On to xanthine derivatives, really just theophylline. Just of note, aminophylline and caffeine are other methylxanthine derivatives, and that's important to think about in terms of caffeine because it's so widely consumed. But you need to keep that in mind when you're considering adverse drug reactions and drug interactions when using theophylline. The pharmacodynamics of theophylline include smooth muscle relaxation. It acts as a CNS stimulant. It has many cardiovascular effects. It can even increase gastric acid production, stimulates skeletal muscle, and has an effect on increasing the GFR. It's absorbed rapidly and completely from the GI tract. It is distributed widely, and the volume of distribution really depends on the patient profile. It's metabolized in the liver and into caffeine, and it's also eliminated through the renal system. It's important to monitor patients with cardiac conditions. As you can see, a host of cardiovascular side effects may occur. Also, we need to monitor for theophylline toxicity, and we need to use it in pregnancy with caution. Those pharmacodynamic effects show up in these adverse drug reactions. We see some CNS effects, which include seizures at levels of 15 to 20, the GI effects of reflux and heartburn, cardiovascular side effects. At high levels of toxicity, we see hyperglycemia, hypotension, arrhythmias, seizures, brain damage, even death. Theophylline has drug as well as food interactions because of the way it's metabolized. So smoking can increase the clearance of theophylline. Benzos are antagonized by theophylline. Beta agonists can cause an additive effect of toxicity. You can see reduced lithium levels. And interestingly, as far as diet, a low carbohydrate, high protein diet will increase clearance of theophylline. And charbroiled foods can accelerate the metabolism of theophylline in the liver. As far as indications, theophylline really doesn't have much role in asthma. It may have some role in patients with COPD, but really is not a drug that we use very frequently with all the other things that are available. Because of the concerns of toxicity, it does need frequent monitoring, and this is partly why it's not used, as well as not being as efficacious as many of the other drugs that are available. Patients need to be aware of the signs and symptoms of toxicity. They need to avoid caffeine in large amounts, and they need to understand how their diet may affect the elimination of theophylline. Now we move on to the leukotriene modifiers. Before we talk about pharmacodynamics of the leukotriene modifiers, we need to revisit leukotrienes, and as you may recall, they play a significant role in inflammation and in the inflammatory process. You can see all their actions on the inflammatory system. So they play a significant role in the chronic inflammation that we see with asthma and allergy. So there are two leukotriene receptor agonists available for use in asthma, Accolate and Singulair, and then we have one lipoxygenase pathway inhibitor called Zyflow. These drugs are not for the primary treatment of acute asthma, and also it's important to avoid abruptly substituting a leukotriene modifier for inhaled steroids or oral steroids. Also, hepatic dysfunction is a real concern with Accolate because it is extensively metabolized in the liver. As far as pregnancy, Singulair and Accolate are safe in pregnancy, but Zyflow should be used with caution in pregnant patients. As far as contraindications, the only real contraindication with Accolate and Montelukast or Singulair are hypersensitivity, known hypersensitivity. Singulair, though, does come in chewable tablets, and that needs to be used in patients that have PKU because it contains phenylalanine. Accolate, again, needs to be used with caution in patients that have active liver disease. In fact, a patient with cirrhosis will have clearance of Accolate reduced by 50 to 60%. Adverse reactions with the leukotriene modifiers, most common is headache. We do see some other GI complaints, myalgias, fever, maybe an increase in respiratory infections. But one of the things we need to be thinking about, which you wouldn't really think about with these drugs, are the neuropsychiatric reactions such as depression, anxiety, agitation. These are the indications for these drugs. Persistent asthma, they're all used for that. Accolate, Singulair, and Zyflow all have indications for persistent asthma. And you can see the ages where it is appropriate to start using them. Singulair is also used in exercise-induced bronchospasm for patients starting at age 6. Monitoring of improving or worsening symptoms of asthma are important with these drugs. Patients often will go on these drugs and feel a lot better and stop using their maintenance therapy, but if they're starting to have a need for their rescue inhaler, for example, then we need to think about what other things need to be added for maintenance. So pulmonary function may need to be checked, and we also need to be on the lookout for the neuropsychiatric symptoms. Our next class of drugs are the antihistamines. As far as pharmacodynamics, it's all about histamine, and you can see the many ways that um, they work in terms of inhibiting histamine, preventing the physiologic effects of histamine at the H1 receptor sites. They also can reduce the formation of edema and the formation of wheals that we see on the skin when patients having an allergic reaction, and they can decrease the itch response as well. So their indications are, of course, for allergies and hypersensitivity reactions, urticaria and angioedema. Patients sometimes will have chronic urticaria and can take antihistamines on a daily basis for prevention. They're also used as a nighttime sleep aid. We know people commonly use Benadryl because of its drowsy side effect, and also they can be used as an antiemetic. There are differences in the first generation versus the second generation antihistamines, with the first generation antihistamines being non-selective to the central H1 receptors, and so because of that, they can cause depression as well as a paradoxical CNS stimulation. Diphenhydramine is still widely used and can have these effects. The second generation drugs are more selective for the peripheral H1 receptors, and so they're a lot less sedating, although they can cause some sedation. Both the first and second generation antihistamines should be used with caution in pregnant patients. In children, the second generations are generally safe to use. First generation, such as Benadryl, should not be used in newborns or infants. And these are the first generation adverse effects. As you can see, they're numerous, and most of us have probably experienced some of those because most of us have used Benadryl, for example, at some point in time. And as you can see, the second generation antihistamines have a lot less side effects, with drowsiness being greatly reduced, as well as the incidence of dry mouth. Our next drug class are the decongestants. The decongestants are sympathomimetics. They are alpha adrenergic receptor agonists that act as sympathomimetics. So they produce vasoconstriction by stimulating the alpha receptors in the respiratory tract, thereby reducing swelling, at least temporarily. And so that causes nasal decongestion. And as you know, the pseudoephedrine, ephedrine, and phenylpropanolamine that we used to see in these drugs has been replaced by phenylephrine because of those being a precursor to methamphetamine. And these are the indications and delivery systems. You can get decongestants in liquid, tablet, capsule, nasal spray, or even drops. Decongestants are contraindicated in patients that are taking MAO inhibitors, and also patients that have severe hypertension or coronary artery disease. Patients that have hypertension should try to avoid taking decongestants, or they should at least be aware that they're going to experience a rise in their blood pressure while they're taking them. And you can see some of the adverse effects, including the more common restlessness and tremors that most people experience. And some patients, even who don't have high blood pressure, may experience some increase in their blood pressure. But you can also see hypotension as a rare cardiovascular side effect. The topical nasal decongestants can also, have their own set of adverse effects with local irritation, sneezing, etc. But the main thing to remember with the topical or nasal decongestants are that they can cause rebound congestion. So they can really relieve that stuffy nose feeling, and patients will use it repeatedly because they feel good, but then with prolonged use, they just get rebound congestion. So the congestion gets worse and worse the more that they use them. They should be limited to no more than 3 days use. And you can see that both the oral and the topical decongestants are useful in relieving nasal congestion. We just need to be more aware of the rebound congestion that you can get with the topicals. And both of them can be used for eustachian tube dysfunction. So that's that cracking and popping sensation, and sometimes pressure and even pain that patients can experience when they are not equalizing pressure. The topical decongestants can work particularly well for that. Our last group of drugs are the cough preparations. The cough reflex is complicated, involving both the CNS and the peripheral nervous system, as well as the smooth muscle of the bronchial tree. And it's important to note that a cough shouldn't be suppressed if it's actually protecting the airway by helping to clear secretions and foreign matter. When it is really just this dry cough, we often want to suppress it so the patient can get some sleep. What we have available to us are over-the-counter dextromethorphan, and usually that's indicated by DM on, the name of the agent that we find over the counter, and that acts centrally on the cough center and the medulla. Prescription-wise, we have codeine, which is a very effective narcotic antitussive, which has direct action on the cough center and the medulla as well. And then Tessalon pearls, they actually can anesthetize the stretch receptors in the respiratory tract, so they calm the cough peripherally. It's important to note, though, they look like pearls, as they are called, and they look like something that you want to suck on. And if you do that, you will experience numbness. So it's important to tell the patient to just swallow those. They are not meant to be sucked on, so you don't get that much effective numbness, although their action is to anesthetize the stretch receptors. Just some precautions. We do need to watch that or advise patients not to just use these antitussives for prolonged periods of time. If they have a persistent cough that's related to smoking, asthma, emphysema, they may have a severe, bronchitis or something that needs to be treated with other agents such as antibiotics. So it's important that they get in to see us if it's lasting longer than 7 days. And they're not really good to use if there are a lot of excessive respiratory secretions. The patient should be coughing those up because that is the protective mechanism of cough, to clear that. The only expectorant that is FDA approved is guaifenesin, and that's very commonly found over the counter. It may provide some relief. Mainly what I tell patients is that an expectorant is meant to keep the mucus from getting too sticky and more easy to deal with when it's more loose. And actually the best expectorant is water, drinking a lot of water. But patients feel better when they're taking some medication, and often they can use guaifenesin without any major concerns for common colds. Expectorants are often an important part of therapy in patients that have COPD to keep the secretions from getting too thick. And as with anything that is used over the counter, we do want to warn our patients not to wait too long to come in if it's necessary. Also, patients that are on ACE inhibitors, as you know, can develop a cough. And certainly you need to address the underlying problem. If the ACE is causing a cough, then you need to switch to something, generally an ARB. Also, the guaifenesin should not be used for a cough related to heart failure. These are some of the common and less common adverse reactions, but generally you don't see too much in the way of reactions with guaifenesin. And that's it.